The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always. Welcome back to the Virtual Curbside. We're talking this month about healthy eating and eating disorders, and we are very fortunate to have Megan Jensen and Nicole Holland back for a third go-round. Thank you very much for coming back.
Happy to be here as always.
All right. Any disclosures that you have developed in the meantime?
Not this time.
Keep sending the side hustles,
And
Paul.
Nicole, we are curating a list of side hustles for you. So we've got 8 to 10 things for you to work on. We've talked about trying to lay the foundation for healthy eating. We've talked about some of the pitfalls for healthy eating with the recognition, as you pointed out at the end of last week's episode, that it's all very, very complicated. Any 5 people in the same situation, it's very difficult to predict which, if any, of those people are going to either develop eating disorders or come through it unscathed. But let's talk about this. So now we want to talk about having hard talks and responding to eating disorders this week. Tell me the red flags that I should be watching for and that I should be educating families about watching for. What are some of the behavioral things that we may see?
No eating disorder is going to be the same as another, but there are definitely some common behaviors that we see. One thing that it doesn't happen 100% of the time, but one thing I often see is a kiddo, an adolescent will kind of start with, I want to eat healthy, right? I am going to start being healthy. And they will start making changes. And then eventually those changes, they start eating less. And then maybe they start exercising more. And eventually, 6 months down the road, they're not joining any family meal that they're having together, or they're not eating at the meals, or they are eating in secret, taking food and going somewhere else. They're focusing a lot on exercise, and that's not exclusive by any means to every single eating disorder, nor does an eating disorder develop every time an adolescent wants to start making some healthy lifestyle changes. But that is a common track that we see, as well as you come downstairs in the morning and food that was there the night before is missing, right? And just kind of noticing little things like that where it just kind of seems odd, where food is there, food isn't there that should be there, they're not eating as much, they are saying that they're being healthy, and et cetera, et cetera. What do you have to add to that, Nicole?
I think one of the components to watch for with eating disorders is and Megan touched on this about family dinners, but the amount of interference that it has in a adolescent's life. There can be a healthy balance of eating and exercise that is healthy, but then when it's taken to an extreme and it starts to impair their daily life, I think that's where we start to see the issues, when they don't want to go to social functions or don't want to be with their family because that becomes their primary focus.
It's tough where the red flag we're looking for is somebody can be couched so easily as, I want to be more healthy. I mean, that's what we're all hoping for. But what you're saying is that it may be a code for unhealthy health, if that makes any sense.
Yeah, it's like that swing of the pendulum, right?
Yeah.
Where we're trying to meet the middle. And generally, I don't think any kiddo starts off with like, I want to develop an eating disorder, I'm going to be healthier, right?
No.
It's usually as they start making more quote unquote healthy choices. I had a patient describe it as, this is even yesterday, the eating disorder goblin, right? That's in her brain. As she started making healthier choices, the eating disorder goblin kind of took it and ran with it. And now we have an eating disorder that we have to kind of deal with. And so, yeah, it's hard to kind of tease out at times what truly is them choosing to be healthier versus this is now disordered eating. But it's definitely something that, if I don't see it currently, because people have eating disorders when they come to see me now, but previously when I would do weight management consultations, if I heard kiddos start talking about, I want to be healthier, not necessarily a red flag, but like kind of a yellow flag would go up in my brain of like, okay, this is something we need to watch really closely.
Which is an interesting, ironic conundrum, isn't it? That I want to be healthier makes you nervous.
Yeah, you wouldn't think that, but here we are.
A-
I've seen it too many times.
Any physical signs I should be sensitive to as a pediatrician, or that parents should be sensitive to?
I know we talk about in the eating disorder treatment world how weight doesn't matter, right? But it does at times, right? Where if you see someone's trending and all of a sudden there's a drop, usually if someone has a restrictive eating disorder, I can tell when it starts looking at a growth chart.
Hmm.
And so if we start noticing pretty significant changes, height stunting, drops in growth, or they're losing weight or just not growing in between appointments with you. Another one I commonly see is if GI stuff comes out of the blue. If they're like, oh, my stomach hurts, or I'm just not very hungry, or I start getting nauseous, the overlap between GI and disordered eating is pretty significant. And oftentimes, eating disorders go undiagnosed because we're trying to kind of go down the rabbit hole of GI stuff when the entire time it's an eating disorder.
I think another big one, and Megan, she knows this and probably would have said it, so I'll just add it because for females, especially in adolescence periods, tracking their menstrual period, either late or if they've had it and then missing it, that's another huge indicator that your body isn't getting enough nutrition, and one that the body does a great job in telling you, like, hey, I'm not getting enough to be healthy right now. So that's another big one as well.
That's a good point. Any emotional changes?
Yes, their personality just goes away. I think one of my favorite parts of my job is when someone comes to me malnourished and it's like pulling teeth to do anything with them. It's very difficult to have conversations and to make progress. But if I can get that person nourished, my absolute favorite part of my job is when their personality comes back because their brain is not stuck in the fight or flight of malnutrition. And so oftentimes they present as anxious. There's often a perfectionistic streak going on, depressed, low energy. And if I can get them nourished, all those things improve. And if they're just presenting as very different mood from what you normally see them as at their annual check-ins with the pediatrician or any appointments in between, if you're noticing major differences, then definitely nutrition is something that I would look at immediately.
There was a pretty significant study done on this back in 1944. I just looked up the date, but the Minnesota starvation experiment. And what they found was when these men who were put in this study were healthy to begin with, and they were put on a restricted diet. And it was more looking at the impact of being prisoner of war at the time. But what they found is when food is withheld, the brain hyper focuses on food. And a lot of times when we talk to patients, the amount of brain space that their eating disorder takes up is 80 to 90% of their day, that they're thinking about food or their next meal or how to avoid a social situation with food or how to purge their next meal. And so if you take that in context of their daily life, there isn't much brain space left for much else. So really, truly, they become a different person because their brain is so preoccupied with food and with eating or anything to do with their eating disorder that they kind of disappear into it.
Very interesting. So let's say that you have a concern. How do you start the conversation?
So, with the Boulder Way Forward campaign that we're working with, one of the initiatives that we're doing is called Chat P2P. So, kind of a spinoff of Chat GPT. Right now, it's a trendy thing, so AI, but we're calling it Chat P2P, meaning person to person. So that's the approach of this whole project: is how do we talk about eating disorders? Because nutrition is such a personal thing, and I think it's hard for anyone, whether that's a parent or a teacher or a coach or a sibling, to know what to say. You see signs, you're worried, but how do you approach it? And a lot of times we see, unfortunately, probably more with parents and what we've been doing with Megan, but how the wrong way to do things can hurt. If you bombard a child and be like, I know you're not eating and we're going to put you in therapy, and a scare tactic generally doesn't work. So I think first and foremost, you always have to approach it with support and love for that individual and not accusing. That's the biggest one right off the bat, is make sure that you're not approaching them in a social public situation and making it a scene. Talk about it privately with them. Say it in a caring, supportive way, like, what can I do to support you? I love you and I care about you and I want to help. How can I help you? Because they're aware that something's going on. Like, they're not unaware of it. And so taking it from a standpoint of I care about you and I love you, not you're going to go to a doctor or you're going to die. That's generally not a helpful way to handle it, and scares the kiddo even more. And then generally they shut down and don't want to talk to the parent. So having a loving and supportive conversation initially. Megan, if there's anything to add.
I think that was great. And definitely scare tactics don't work, because then they come to me and the guard's up and this isn't a problem. Everyone's exaggerating, right? And I think about when people talk about how to prevent suicide, right? And there's a concern that if I say something, it's going to make it happen. It's going to make it worse. When in reality, the research clearly indicates that not talking about concerns for suicide is not the answer. Talking to someone, expressing concern, and coming at it from support. Eating disorders are the same way, where the answer is not, oh, if I just ignore it, it'll go away, or if I say something, it'll make it worse. Definitely having the conversation, being supportive and loving is the answer, I think, to most things in life, but definitely in this situation.
Yeah, I mean, it seems like it's analogous to substance issues, to suicide prevention, and that it's a trick of finding a way to be an advocate, not an enabler, and to make sure that you're on their side.
I think as parents, our two primary roles of parents is A, prevention, and then B, support. I think it's tricky sometimes because parents want to fix it and they don't have the tools necessarily when it gets to a degree of an eating disorder. And so knowing that there are specific resources, there are dietitians like Megan who specialize in eating disorders. And it is almost always an interprofessional team. There's a dietitian, there's a mental health specialist, there's a pediatrician. So recognizing that there are those resources available and it is something that needs specialized treatment.
On that subject, how do we best engage a family? Because there are a lot of moving parts. A family may feel guilty about what's going on. A family may feel denial about what's going on. And a family, as families are, we're all parts of families, we may approach this dysfunctionally in a way. What's the best way to engage family for this?
One thing that I will often talk about with patients and families is I'll ask them, if this were a strictly physical condition without a psychiatric component, how would you respond? If this was cancer, if this was heart disease or diabetes or kidney disease or insert whatever, how would we respond? One comparison that I often make is I'll talk to patients specifically about the diagnosis of diabetes, and we'll talk about how that is done, what an hemoglobin A1C is, and if someone has a hemoglobin A1C of 7% and then someone else has one of 12%, they both have diabetes. One might clinically be a little bit more medically compromising, but they both have diabetes. And so when I talk to families and I kind of give this comparison, I say, we're telling you this is a problem. This is disordered eating. It doesn't matter what the A1C is. It doesn't matter what percentage we're at, because we meet the criteria. I'll often talk a little bit about that, kind of make that comparison, but also say, yeah, once again, how would you respond if this was a completely medical versus psychiatric condition? And usually the answer is, well, we just do whatever is required and we just get it done. Say, great, this is what's required. Also understanding and kind of describing to them just like any of these other medical conditions I've listed, you can't necessarily predict that it's going to happen. And it doesn't matter if there was something that you said years ago that may have possibly contributed to this. We have something that needs to be addressed. And yes, maybe there's some guilt, but there's also times with eating disorders where parents did everything, quote unquote, and the eating disorder still developed. Just like how someone can do everything in their power to prevent diabetes, but it can still develop. And so that's generally the comparison that I make with other medical conditions that people are more comfortable talking about as we kind of work on the language and the treatment around an eating disorder.
Yeah. Parents were always capable of enough guilt and magical thinking that we can find that we caused anything. And I think what you're saying, Megan, is so incredibly important. This idea that you may search your soul and wonder, is there something you did or didn't do? But the fortunate thing, isn't your child so lucky to have you along for the journey and to be so supportive and to be there with him or her while it's happening?
Yeah, there's lots of patients where they don't. It's really difficult to treat them just because they don't have that support.
Right.
I think as a parent, one of the biggest lessons that I've learned is they're little people. And despite what I want for them and what I think is best, they're going to make whatever choices they end up making. And as parents, we can support them and give them structure and teach them, but eventually they're going to make decisions on their own. And so I think that's a struggle with eating disorders as well, because as a parent, you want to fix it. Another thing that we'll hear a lot that's not helpful is a parent will say, you just need to eat, just eat. And they want to take that control. And believe it or not, that doesn't work because there is such a mental side of it that we have to address, that it isn't just the physical. One of the best ways that a family can support a child, treat them like a human and not their condition. I've heard Megan say in appointments before, like, if someone has cancer, you wouldn't treat them like that condition or just focus on that. Like, they're still your child. They still have other interests and hobbies and 1,000 other things about them that we want to focus on. The eating disorder is a separate entity in a lot of the ways we discuss it. We name it. A lot of times we come up with some fun names. And so we can talk about it in a third person way. That way we can separate the child from the eating disorder. And it's helpful for parents to do that too, so that they can still see their child as their child. And it's not all just about, what are you eating? Did you eat enough today? Are you doing this? Are you doing that? Talk about their hobbies, talk about their friends, support them and get them the resources they need. And again, don't ignore it. Like, it's not a black or white thing, but at the same time, recognize they're still a human and treat them as your child still.
Yeah, they're first and foremost a human. And the other thing that I think, and we talked about this a couple of years ago when we talked about eating disorders, but the advantage we have, I think, in our current system is this idea of a multidisciplinary approach to this, that you guys definitely are the center of what we're doing, that a good therapist is central to helping everyone, I think, come to grips with the burden that this is to carry sometimes, that physicians who specialize in this can be so incredibly helpful in making this, and that you all work together. And I think that the existence of a program like you have is one way that we not only treat people, but I think we instill hope by saying, look, this thing is in place, and there are a lot of people who will work with you to help make this happen.
What I often tell parents as well, let me be the bad guy. Let me be the one that they're accountable to. Let me be the one that really has these hard conversations, or be a mediator for hard conversations, so that you can focus on being a parent. Get them to appointments. Let us be the ones that confront them on these things that are happening, and let me be that person, because your number one job right now is to be a supportive and loving parent. And
Right.
I don't care if they don't like me, but I care if they don't like you. So,
Yeah.
and most of my patients like me, I promise. But that's usually the conversation I have, so that parents can relax as much as they can, given the situation.
I can tell you for a fact that I know that your patients tend to like you because we share some patients, and I think you're very helpful. But I think that because this sits so squarely in a life function and eating. I don't think parents beat themselves up if they don't feel like they're an expert and oncologist, but I do think they tend to beat themselves up if they are struggling with something like this. I think your message is so incredibly important and hopeful that we want parents to be able to parent and embrace all the personhood, and then you're going to help deal with this problem.
Yeah. Because anything I can do to help them relax. And then I go to work building rapport with their kiddo so that their kiddo will tell me things, right? And be honest with me. And it can be a hard dynamic, but we're in this for the long run.
I think one of the important things to also recognize as a parent is it's not a condition that you treat and it goes away. It unfortunately is something we learn to cope with and learn healthy ways of thinking. But your job as a parent isn't like, I think when our kids are little and they fall and they get a scrape on their knee, you slap a Band-Aid on it and then it heals and it's good and you're good to go. And I think recognizing your job as a parent is to provide a safe place. It's to sit down and say, hey, why don't I sit down and eat with you? And not to watch what they're eating, but to provide that support in that social system. Or I'm really proud of you for making it to treatment today. And recognizing that it is going to be an ongoing battle and providing that support and really cheering them on and not expecting them to go to 2 appointments and then come back, air quotes here, fixed. Because that isn't a thing. And I think we see that a lot with parents too, is they say, well, they went to a treatment center. They should be better by now. Why is this a thing? Recognizing it as an ongoing issue that is manageable and you can have a healthy mindset about it in the future for sure. Like there's hope, but also don't expect your kiddo to go to 2 or 3 appointments with Megan and then come out and be magically good to go. Take a long-term view of it and recognize your role as a parent is support them through that and to provide a safe social support as a parent.
Which why the analogy with the diabetes is much more fitting than an analogy of a broken arm that's fixed and you move on. Well, this has all been very, very helpful. You want to put in another plug for the Boulder Way Forward program?
Yes. We are on top of working with Intermountain and treating eating disorders there. We are part of a program out of Utah State University, which is my alma mater. So I love everything and everything that comes out of Utah State as an Aggie. But they are really passionate about this Boulder Way Forward program to decrease the inequities between men and women in the state of Utah. And so we, as has been stated before, represent the section that is about eating disorder prevention and lifelong health. I know that what we talked about today included obviously both male and female adolescents, which is super important. And we are just really passionate about this program and hope that those that aren't aware of it will become aware of it and maybe join us in our efforts to be able to decrease those inequities.
I'll just add, the handout that we have been making, I think I have been honored to be such a part of it because it's important. It goes through what to look for eating disorders and then how to talk about it and how to kind of tackle it. Because I think a lot of times as parents, like you mentioned, it's scary and they don't know how to. So just being aware of that resource, that we are developing ways to talk to your kids about it and then ways to find those additional resources so you can get your team on board to help with the treatment.
Perfect. Well, Megan Jensen, Nicole Holland, thank you so much for your time and your expertise over the last 3 weeks. There have got to be questions, so we'll look forward to talking about those next week. Please send your questions to questions@vcurb.com. To our listeners, thank you very much for listening. Thanks for telling your friends about us, and thanks for your feedback. We always appreciate that. Thank you to Elisa Stoddard for making this sound like a podcast, and thanks, Janice, for listening. We'll talk to you all next week. Thanks for joining us. We look forward to getting together again next time. The Virtual Curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics.
The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, the content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Elisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Production design, thanks to Phil Wirkus, who also composed the theme music. See you next time.